Welcome back to the series. Today we're covering the support trial's oxygen saturation arm, published by Carlo and colleagues in 2010. If you watched our episode on the CPAP versus surfactant arm of support, this is the companion trial. Same infants, same era, different randomization question. This one asks how tightly we should be controlling oxygen in our smallest, most fragile babies. It's one of the most cited and most debated trials in neonatology, partly because of what it found, and partly because of the ethics controversy that followed. Stick around for both. Here's the sentence that made this trial famous, in plain terms. Neonatologists had spent decades going back and forth between generous oxygen, which risks retinopathy of prematurity, and restricted oxygen, which risks death and brain injury. This trial tried to settle that trade-off with a randomized answer, and the result was more complicated and more consequential than anyone expected. Let's look at the question they actually set out to answer. Framed as a PI co-question, this is what the support investigators asked. Among infants born between 24 and 27 weeks, does targeting a lower oxygen saturation of 85 to 89%, compared with a higher target of 91 to 95%, change the combined rate of severe retinopathy of prematurity or death before hospital discharge? It's a deceptively simple question, and getting a clean answer to it required a huge multi-center effort. Let's talk about why this question needed asking in the first place. So why did we need this trial? For years, the field had been caught in a tug-of-war. Push oxygen saturations too high, and you raise the risk of retinopathy of prematurity, ROP, a leading cause of preventable blindness in preterm infants. Push them too low, and older data hinted you might raise mortality or brain injury. Clinicians were essentially guessing at a safe middle ground without solid randomized evidence. The support investigators wanted a real answer. Is there meaningful extra ROP risk hiding in the higher end of what we'd been calling a normal saturation range? Now, let's look at how they actually built the trial to answer that. Support stands for Surfactant, Positive Pressure, and Oxygenation Randomized Trial, and it ran across more than 20 centers in the Neonatal Research Network from 2005 to 2010, enrolling 1,316 infants. Here's the detail that trips people up. This was a 2x2 factorial design, meaning infants were randomized twice, once to a respiratory support strategy in the delivery room and once to an oxygen saturation target for routine NICU care. We covered the respiratory support comparison, CPAP versus surfactant, in its own episode. Today, we're focused entirely on the oxygenation randomization. Let's look at exactly who was eligible. The population here is about as fragile as neonatology gets. Infants born between 24 and 27 weeks gestation, where a decision had already been made to provide full resuscitation. So this isn't a comfort care cohort. These are babies actively being treated to survive. Exclusions were minimal, basically outside-born infants who couldn't be enrolled in time, and babies with major congenital anomalies that would confound the outcome picture. That broad, pragmatic eligibility is part of why this trial's results carried so much weight. It looked a lot like real-world extremely preterm practice. Now, the intervention itself. Here's the intervention in its simplest form. Within 2 hours of birth, infants were randomized to one of two oxygen saturation targets, a lower band of 85 to 89% or a higher band of 91 to 95%, continued until 36 weeks post-menstrual age or until the baby was on room air. The clever part, and the part that later drew criticism, was the blinding strategy. Caregivers used modified pulse oximeters that displayed a shifted reading between 88 and 92% for everyone, so nobody at the bedside could tell which group a baby was in just by looking at the number, at least within that overlap zone. Below 85 and above 95, the oximeters showed true values in both groups. Keep that blinding detail in mind, because it matters a lot for interpreting the results. Let's look at what they were actually measuring. The primary outcome was a composite: severe retinopathy of prematurity, or ROP, or death, whichever came first, assessed before hospital discharge. Bundling those two together makes sense clinically, since a strategy that trades eye disease for survival, or vice versa, needs to be judged on both at once. Secondary outcomes rounded out the safety picture: bronchopulmonary dysplasia, other safety events, and how long infants needed respiratory support. With the endpoints defined, let's get to what they actually found. because this is where the trial gets interesting.
Now for the headline numbers. On the primary composite outcome, severe ROP or death, the lower and higher saturation groups did not differ significantly, an adjusted relative risk of 0.90 with a confidence interval crossing 1. But break that composite apart and you see why this trial became so influential. Death before discharge happened more often in the lower saturation group, 19.9% versus 16.2%, a statistically significant difference. Meanwhile, severe ROP among survivors was cut roughly in half in the lower saturation group, 8.6% versus 17.9%. So the composite looked neutral, but underneath it, one group traded some survival for a lot less eye disease. BPD and ventilation duration didn't differ meaningfully. Let's put that trade-off into a visual. This chart puts the trade-off side by side. On the left, mortality was higher in the lower saturation group. On the right, severe retinopathy was far lower in that same lower saturation group. There's no free lunch here. Tightening the oxygen target downward brought a real reduction in blinding eye disease at the cost of a real increase in mortality. That's the kind of result that forces a genuine values conversation among clinicians and families, not just a protocol change. Before we get to the clinical takeaway, let's talk honestly about the limitations of this trial. No trial this important escapes scrutiny, and support has plenty. The biggest issue is that the blinding, despite a clever masking algorithm, didn't achieve the separation the investigators wanted. The median saturation in the lower target group actually ran above 90%, meaning many of those infants weren't really living in the 85 to 89% range as intended. Technical artifacts in the masking algorithm and variable nurse-to-patient ratios both likely contributed to that imprecision. And unlike earlier oxygen trials, this one started in the delivery room rather than after NICU admission, which may partly explain why its results look different from prior work. These aren't fatal flaws, but they matter when you're deciding how much weight to put on the exact numbers. So what happened after this trial was published?
Here's how the evidence evolved. Follow-up of this same cohort at 18 to 22 months corrected age found no significant difference in death or neurodevelopmental impairment between the two target groups, which was reassuring given the in-hospital mortality signal. Support then became one of 5 trials pooled in the NEO-PRM collaboration, the Neonatal Oxygenation Prospective Meta-Analysis, combining individual patient data from almost 5,000 extremely preterm infants. That pooled analysis found no overall difference in death or major disability between lower and higher targets, though the effect on ROP wasn't consistent across all 5 trials. By 2016, the American Academy of Pediatrics had weighed in, suggesting a target around 90 to 95% might be safer for some infants than the lower band tested here. Let's bring this to a clinical bottom line. So what should you take away from all this? First, there's no universally safest saturation target. The honest answer is that it depends on which risk you weight more heavily for a given infant and unit. Second, remember the core trade-off. Dial saturation's lower and you cut severe ROP substantially, but you may pay for it in survival. Third, this trial is also a reminder that hitting your intended target precisely at the bedside is its own challenge, separate from picking the number in the first place. And finally, most units today have settled closer to the 90 to 95% range, shaped by both support and the pooled neoprome data. Before we close, let's hear directly from the trial's lead investigator. This trial didn't just generate clinical data, it also sparked one of the bigger research ethics debates in recent neonatology history. Federal regulators initially raised concerns about whether the informed consent process adequately conveyed the risks of comparing 2 saturation ranges that were both, in isolation, considered standard of care. Dr. Carlo, the trial's lead investigator, describes the response that followed: an NIH symposium, ethicist conference calls, and public letters in the New England Journal of Medicine from more than 40 bioethicists and pediatricians, plus NIH leadership, defending the trial's design and consent process. The consensus that emerged was that the trial had been conducted appropriately, and NEJM's own editors later called it a model for how this kind of comparative effectiveness research should be done. It's worth remembering that debate whenever you're weighing 2 already accepted therapies against each other in a trial design. Let's close out with the references. That's a wrap on this study.
Full citations are on screen if you want to read the primary trial, the meta-analysis, or the AAP guidance for yourself. Thanks for watching, and we'll see you in the next episode of 50 Studies Every Neonatologist Should Know.